Assalamu alaikum. The second lecture about pancreas is about the tumors of the pancreas. Our objective is to understand the benign pancreatic tumor, the malignant pancreatic tumor, which is the most common subject, what is meant by periampullary tumor, and how can we prepare the patient with preoperative workup for patient with pancreatic tumor, especially if it is in obstructive jaundice, and small notes or some points about the surgical treatment of pancreatic tumor. Benign pancreatic tumor could be from the duct. We call it intra-ductal pancreatic mucinous neoplasm. It's a premalignant condition characterized by papillary projection from the epithelium, and is higher risk for malignancy, diagnosed by endoscopic ultrasound, and treatment is excision depending on the size of the tumor. Insulinoma, from its name, is an insulin-secreting tumor. The important point is the characteristic presentation. We call it total triad, fasting hypoglycemia, symptoms of hypoglycemia, irritability, altered consciousness, palpitation, which is relieved by administration of glucose. It has special diagnosis with the serum of insulin, and characterized by severe hypoglycemia. Treatment with localized excision, we call it inoculation, just localized excision of the tumor depending on the size. Zollinger-Ellison syndrome is a gastrin-secreting tumor, and Werner-Morrison syndrome characterized by production of the IP, active intestinal peptide, and it is rare, but we must know their name. Glucagon-secreting tumor characterized by diabetes, weight loss, and venous thrombosis with ascites. It's a rare condition, and it could be benign, could be malignant, and the treatment is excision. Now we are concentrating about the most important subject in this lecture, and you must concentrate on it because it is one of the leading causes of death in the world. 6th leading cause of cancer in the world. There is no simple screening test, so it could be presented, or most of them presented late. Why it is late depends on because the site of the pancreas is retroperitoneal and can lead to severe or distant metastases, or with secondaries, or with local invasion, without or with a mild symptom. More than 85% they present the origin from the duct. The remaining tumor comes from the island cell. Ductal adenocarcinoma is mostly in the head of the pancreas, solid, scirrhous, and characterized by tubular glands with desmoplastic fibrous stroma. Small notes about the pathology: could be cystic, could be solid, and cystic characterized by large size presentation, solid small size with early presentation, and could be confused with pseudocyst. We know that pseudocyst is some of the end results of the pancreatitis. Periampullary tumor is very important subject to know what is meant by periampullary tumor. Periampullary tumor is any tumor around the ampulla of water. Could be the origin from the duodenum, could be origin from the lower CBD, could be the origin from the head of pancreas, or other malignant tumor or benign tumors or malignant tumors around the ampulla of water. Could be a part of neuroendocrine tumor. Okay, it is the 1/3 of the tumor in this area. Why we separate this tumor from the other tumor. Why we don't call it only cholangiocarcinoma, or we call it only pancreatic tumor, or we call it only duodenal tumor? They have more favorable prognosis. Why it is favorable prognosis? Because they have an early presentation, early symptoms. The patient presented with special type of jaundice, we call it post-hepatic jaundice or obstructive jaundice, and presented early and diagnosed early and have a good prognosis that separates them from the innate or the original tumor, separate from pancreatic tumor. So they have special entities, special presentation, and a special prognosis. In general, carcinoma of the pancreas, they presented depend on the site of the tumor. Most of the if the tumor in the head of pancreas, they presented with post-hepatic jaundice. We call it obstructive jaundice, which is painless, mild nausea, gastric discomfort, pruritus, deep colored urine or tea colored urine, pale or clay colored stool with steatorrhea. Could be presented with upper abdominal symptoms that recently with diabetic patients in over 50 years patient with no family history or no history of obesity. This patient is a 50 years old male presented with deep colored urine, deep colored. This urine is especially for the deep colored urine, tea colored urine, and this is characteristic of the clay colored stool, a pathognomonic features of. If the tumor situated in the body and tail, they presented vague discomfort, anorexia, weight loss, and usually it is missed or can be misdiagnosed as mild dyspepsia, peptic ulcer disease, GERD, so on, irritable bowel syndrome. But when we found such symptoms with a worrying or a pain in the back, you suspect an retroperitoneal infiltration. Rarely they present with unexplained attacks of pancreatitis due to obstruction of the duct, or maybe silent. Silent means he presents with secondaries or presented with unknown primary, or secondary from unknown primary. On examination, if the patient have an obstructive jaundice, and you know that the obstructive jaundice have many differential diagnoses, for example, cholangitis, presented with a recurrent CBD stone, presented with tumors in the pancreas, so present with flukes or body flukes or space increases in the CBD. If when examination we palpate the patient and find this patient with obstructive jaundice have palpable gallbladder, and because of the tumor is pancreatic tumor, we call it covercelo. Means, but if the patient with obstructive jaundice secondary to CBD stone, we cannot palpate the gallbladder. Is it clear? Means, covercelo, when a patient with obstructive jaundice and your examination, we palpate the gallbladder and find palpable gallbladder, means covercelo means this jaundice, or most likely this jaundice caused by pancreatic tumor. If patient with obstructive jaundice and we palpate the abdomen or found non-palpable gallbladder, this is unlikely to be a tumor in the pancreas. Okay. Other signs of intra-abdominal, we call it covercelo. Other signs of intra-abdominal malignancy should be looked for and should be cared. For example, ascites, supraclavicular lymph node, we call it the virtuous lymph node, or a tumor deposit in the pelvis. For this unlucky woman presented with just mild discomfort, and I find a bulge or a mass found in her umbilicus. She's completely just cachexia. Look to her face. To her face, she's cachexic, weight loss, and plus a mass in the umbilicus. This is called cystergicial nodules, means hidden malignancy. How can we investigate a patient with suspected pancreatic tumor? Starting from the simple bedside investigation, complete blood picture give us a hint about the anemia or iron deficiency anemia. Liver function test, typical presentation of obstructive jaundice. Ultrasound can be diagnosed the gallbladder thickness, distension in the CBD, whether this inadequate or good practitioner can suspect a pancreatic tumor. But the most important pathognomonic is in contrast enhanced CT scan to diagnose this tumor. The majority of the instances should be established if the tumor is pancreas and it is resectable. The presence of hepatic and peritoneal metastasis during investigation, lymph node metastasis distant from the pancreatic head, encasement of superior mesenteric or hepatic or celiac artery by the tumor are a clear contraindication to surgical resection. ERCP is meant by endoscopic revisit cholangiopancreatography as stenting indicated if there is any suggestion of cholangitis, if there is diagnostic doubt, if the patient is deeply jaundiced, or there are distressing symptoms, for example, pruritus, in order to palliate his jaundice or his. Endoscopic ultrasound usually starts transduodenal or transgastric fine needle aspirate to document the diagnosis or document the histopathological histopathology of the tumor. Management. The most important management in patients with pancreatic tumor, especially obstructive type of jaundice, is not your job to treat this patient or to do surgery for him. But the most important, as you as a resident in our hospitals after a few years, is how can we prepare the patient to surgery. It is important to mention that more than 85% of patients with ductal carcinoma, adenocarcinoma, is unsuitable for resection. For resection, constraint. It is not for palliation. يعني patient with patient with pancreatic tumor could be not resected in 85% of people. If cystic tumors, whatever its size, it is favorable prognosis and can carry good resolvable prognosis if we excise the tumor. Okay. Few important things. The surgery is called Whipple procedure. Just know the name. It is Whipple procedure, characterized as mentioned in or as noticed in this picture. Is pancreatic duodenectomy. Okay, it is called pancreatic, and these 15% of resectable tumor. Just for information, it is not mentioned. If it is in the tail, we call it distal pancreatectomy with splenectomy. Okay, in the 85%, we do palliation. Palliation could be surgical or could be endoscopic. Surgical, we do surgery just to bypass the tumor, while endoscopic, bypassing an endoscope or an stenting to bypass the tumor. For example, this stent to bypass the CBD, or this stent to bypass the duodenum, just for palliation. Just for palliation. Okay. The most important is how can we prepare the patient to surgery. How can we prepare the patient with surgery? We prepare them with 6 important points should be prepared before doing surgery to patient with obstructive jaundice. Number 1, the patient preoperatively should be giving a 5% glucose water, means rehydration, plus mannitol, 200 ml, 20% twice daily, so a rule of 2, in order to prevent hepatorenal shutdown. We know that patients with obstructive jaundice have a raised conjugated bilirubin, and this conjugated bilirubin is of large particle, could precipitate the glomeruli and causing acute renal failure. To prevent that or to minimize that, we give the patient intravenous fluid plus monitor. Vitamin K. Why we give vitamin K in such patients? Vitamin K is because patient with obstructive jaundice have deficiency in absorption of vitamin K dependent clotting factor اللي هو 10, 9, 7 and 2. In order to prevent that, we give parenteral vitamin K, means intramuscular vitamin K, 10 milligram until improvement in the prothrombin time, and the prothrombin time should be 1.5 and above. Antibiotic should be giving parenteral antibiotic during induction of anesthesia against gram-negative bacteria, for example, third generation cephalosporin or aminoglycoside, to prevent hospital-acquired infection, nosocomial infection, wound infection. Laxative, we give the patient laxative in form of PEG. PEG اختصار polyethylene glycol, in order to decrease the number of bacteria in the GIT. When the number of bacteria in GIT should decrease, the production of ammonia decrease and the absorption of ammonium decrease, and this is decrease the incidence of hepatic encephalopathy and prevent the CNS disturbances after the surgery. The same result is from the non-absorbable antibiotic, for example, neomycin or erythromycin base or metronidazole, to decrease the incidence of absorption of ammonium content and absorption of ammonium, decrease in hepatic encephalopathy. And we must manage the patient with pruritus. It's important to mention that pruritus is one of the severest or the worst presentation of patient with obstructive jaundice. Could be very irritable, very severe, and we must treat it with chenodeoxycholic acid or bile salt chelating agent to suspect or to minimize such incidents. But the most important point to decrease the pruritus is by doing the surgery. Okay. بهالحالة انتهت المحاضرة مع البنكرياتيك tumors, and now I have suggested tumors, suggested questions to refresh you about the refreshment about this lecture. For example, in patient with acute pancreatitis in the previous lecture, we discussed about the prognostic criteria about ransom. These are suggested, and we have this about the treatment of the chronic pancreatitis and the ulceration. Just refresh your information with such. And I have another lecture about summary to these pancreatic diseases, the lecture 1 and lecture 2, to help you to summarize